Hello, I am Hematologist Oncologist Dr. Tony Talebi, and this lecture pertains to the Non-Hodgkin's Lymphoproliferative Disorders of Hematology and Transfusion Medicine Board Review Made Simple. Lymphocytes develop from a common lymphoid progenitor cell. B cells mature in the bone marrow and lymph nodes, whereas T cells mature in the thymus. B cell maturation, 2 steps involved: early antigen-independent and late antigen-dependent stages. Early development. B cells are produced in the bone marrow. Development is initiated by the rearrangement of genes for the heavy and light chains of antibodies, a process referred to as VDJ recombination, to produce a unique variable domain in the immunoglobulin of each individual B cell. CD10, called CALA, common acute lymphoblastic leukemia antigen, CD19, TDT, terminal deoxynucleotide transferase, are expressed at this stage. Once CD20 is expressed, CD10 and TDT are lost. Late development. B cell has left the marrow and migrates to the spleen and lymph nodes. The B cells then assemble in terminal center of lymph nodes or the spleen and undergo somatic mutation, mutations into the variable region genes to change affinity of the antibody to the antigen. Important to note that many of the lymphomas occur during the somatic mutation, in which failure of these processes may result in inappropriate translocations, for instance oncogene to immunoglobulin switch region, or point mutations in oncogenes. B cells with a correct affinity to the antigen survive and are converted to plasma cells. T cell maturation takes place in the thymus both in adults and children. The 4 T cell receptors, the TCR genes, are alpha, beta, gamma, and delta, which undergo rearrangement. T cells undergo positive and negative selection. In positive selection, they must react against allogeneic antigens in context of MHC. In negative selection, they must not react too strongly with autoantigens. 98% of T cells undergo apoptosis during this process, as they do not meet the strict criteria for negative and positive selection to survive. They express CD3, CD4, CD5, and CD8. The theory of autoimmunity is T cells which react too strongly to self-antigens do not undergo apoptosis during negative selection, and they will cause autoimmunity later on in life. Stages of lymphoma. Stage 1, a single lymph node region or a single extralymphatic organ or site, that would be 1E. Stage 2, 2 or more involved lymph node regions on the same side of the diaphragm, or with localized involvement of an extralymphatic organ or site, that would be 2E. Stage 3, lymph node involvement on both sides of the diaphragm, or with localized involvement of an extra-lymphatic organ or site, stage 3E, or spleen, stage 3S, or both, stage 3ES. Stage 4, diffuse or disseminated involvement of one or more extra-lymphatic organ, including liver, bone marrow, lung, etc., with or without associated lymph node involvement. All cases are subclassified to indicate the absence or presence of systemic B symptoms, including unexplained fever, night sweats, weight loss exceeding 10% of body weight in the last 6 months. Designation E refers to the extranodal contiguous extension that can be encompassed within an irradiation field appropriate for nodal disease of the same anatomic extent. A single extralymphatic site as the only site of disease should be classified as 1E rather than stage 4, and designation S refers to splenic involvement. Classification of B cell lymphomas. Precursor B cell lymphomas are discussed in the ALL chapter. Here, let's discuss the mature B cell lymphomas. They're classified into the indolent and aggressive. The indolent include the small lymphocytic lymphomas, SLL, lymphoplasmacytic lymphomas, the Waldenstrom is a case of IgM, follicular cell lymphoma, B cell prolymphocytic leukemia, marginal zone B cell lymphoma, and mantle cell lymphoma. Now, the aggressive can also be mantle cell lymphoma, diffuse large B cell lymphoma, Burkitt's lymphoma, primary CNS lymphoma, age-related lymphoma, primary effusion lymphoma, mediastinal lymphoma, intravascular large B cell lymphoma, and double-hit lymphoma, the BCL2 and MYC. Now, the classification of T cell/NK cell lymphoma, the precursor T cell lymphomas, they're discussed in the ALL chapter. As far as the mature T-cell lymphomas, they're divided into nodal, extranodal, leukemic, and cutaneous. Nodal group includes peripheral T-cell lymphoma, anaplastic large cell lymphoma, ALK positive, better prognosis, ALK negative, worse prognosis, and angioimmunoblastic T-cell lymphoma. The extranodal group includes the hepatosplenic T-cell lymphoma, enteropathy-associated T-cell lymphoma, intestinal T-cell and NK cell lymphoma, Nasal-Type T-cell and NK cell lymphoma, panniculitis-like T-cell lymphoma. The leukemic group encompasses adult T-cell leukemia lymphoma, which is HTLV1 associated, T-cell chronic LGL leukemia, aggressive NK cell leukemia, and T-cell prolymphocytic leukemia, the PLL. The cutaneous group encompasses mycosis fungoides of Sézary syndrome, primary cutaneous CD30 T-cell lymphoma, and primary cutaneous aggressive CD8 positive T-cell lymphoma. Now, the Hodgkin's, what we discussed in a different chapter, but quickly, the classical Hodgkin's includes the nodular sclerosis, mixed cellularity, lymphocyte-rich, and lymphocyte-depleted. And the second major classification is the nodular lymphocyte-predominant Hodgkin's, which is CD20 positive. Now, chromosomal translocations that you must know for the boards. Follicular lymphoma, translocation 1418, overexpression of BCL2. Mantle cell lymphoma, translocation 1114, with cyclin D1 overexpression. Burkitt's lymphoma, 3 major translocations. Translocation 28, 814, 822, the fusion of Ig genes to the c-MYC. Diffuse large B-cell lymphoma, the germinal center type overexpressed BCL6 mRNA, and the post-germinal center overexpressed BCL2, which is poor prognosis. Very important to know these two. Anaplastic large cell lymphoma, translocation 25, fuses the ALK gene with nucleophosmin. Marginal zone lymphoma, translocation 1118, MALT1 translocation. The infectious organisms which are associated with lymphomas include H. pylori, gastric MALT, orbital chlamydia pustaki, adnexal orbital MALT lymphoma, Borrelia, cutaneous MALT lymphoma, Campylobacter, small intestine lymphoma, Epstein-Barr, which will include Burkitt's, post-transplant lymphoproliferative disorder, extranodal NK T-cell lymphoma nasal-type, and Hodgkin's mixed cellularity, herpes 8, including Kaposi's, primary fusion lymphoma, and Castleman's disease, and HTLV, which will include T-cell leukemia lymphoma endemic in Asia and the Caribbean. Diffuse large B-cell lymphoma, case report. 56-year-old Caucasian man with emphysema presenting with a 3-week history of generalized fatigue, dyspnea, decreased appetite, fevers, and a 10-pound weight loss. So B symptoms. EGD reveals a large 10-centimeter mass at the G junction with irregular margins and necrotic appearance, which is biopsy. Histopathology reveals a diffuse infiltration, this is a keyword, with large number of intermediate to large pleomorphic neoplastic lymphoid cells that are CD20 positive, PAX5 positive, 45 positive, BCL6 positive, remember BCL6 germinal center type, and Ki proliferative rate approximately of 50 to 60%. Important because if the Ki proliferation was more than 90%, that would be Burkitt's. These findings are consistent with high-grade diffuse large B-cell lymphoma. Bone marrow biopsy reveals normal cellular bone marrow without lymphoma involvement. PET scan reveals enlarged lymph nodes with SUV more than 3 above and below the diaphragm. HIV negative, always check HIV. Echo revealing EF of 65%, always check echo in anticipation of anthracycline, and beta-2 microglobulin elevated. Diffuse large B-cell lymphoma is the most common histologic subtype of non-Hodgkin's lymphoma, accounting for approximately 25% of non-Hodgkin's cases. Systemic B symptoms, which is fever, 10% weight loss, drenching night sweats, are observed in approximately 30% of patients, and serum LDH is elevated in over half. Ki-67 of more than 90% is worrisome for Burkitt's, not diffuse large B-cell. Extranodal involvement occurs in 40% of cases. Perform lumbar puncture if more than one extranodal site, testicular, or paranasal involvement, as well as if the patient is HIV positive. Diffuse large B-cells generally express pan-B-cell antigen 19, 20, 22, 79, as well as CD45, PAX5, along with monoclonal surface membrane. The germinal center diffuse B cells are CD10 positive, MUM1 negative, remember MUM1 is a myeloma marker, BCL6 positive, and have a better prognosis. The non-germinal centers are CD10 negative, MUM1 positive, BCL2, and have worse prognosis. Remember, BCL2 is an independent worse prognostic indicator. Overall survival is based on the IPI, the International Prognostic Index. You get 1 point for each. Age more than 60, stage 3 or 4, performance status ECOG 2 to 4, elevated LDH, and more than one extranodal site. Based on the IPI score, the 5-year survival is at 0, 95%, 1 to 2, 80%, and anything more than 3, about 50%. Treatment of diffuse large B-cell lymphoma. If it's early stage, stage 1 or 2, then limited R-CHOP, which is rituximab, cyclophosphamide, doxorubicin, vincristine, and prednisone, for 3 or 4 cycles plus radiation therapy, except if early stage consists of bulky disease, which is more than 10 centimeters, or extranodal involvement, in which case treat like stage 3 or 4. If it's extensive disease, stage 3 or 4, then R-CHOP times 6, plus or minus radiation to the extranodal sites. If it's relapsed or primary refractory, any salvage chemotherapy regimen, such as RICE, or DHAP, or DSHAP, and if chemotherapy sensitive, complete or partial response, then consolidate with autologous stem cell transplant. Pearls for the boards. R-CHOP 14 versus R-CHOP 21. There's no difference in outcome in R-CHOP 14 with more cytopenias. There's no role for rituximab maintenance, unlike follicular lymphoma. And if PET scan is positive after 2 cycles, a very poor prognostic indicator. If PET scan is still positive after 4 to 6 cycles of R-CHOP, must biopsy to prove persistence of disease before changing therapy, as there's increased rate of false positive on PET scan. Follicular lymphoma. Case report. 66-year-old male presenting with fatigue, palpable lymphadenopathy in the cervical, axillary, and inguinal region, palpable splenomegaly. Excisional biopsy, remember, never do fine needle aspiration. Of lymph node histology revealing a grade 2 follicular large cell type. Immunoperoxidase studies reveal CD20 positive, 10 positive, BCL6 positive, BCL2 positive, and CD5 negative. Slight positive staining for kappa light chain restriction. CD3 is negative, consistent with B-cell phenotype. Bone marrow biopsy and CT scan chest, abdomen, and pelvis negative. HIV negative, CD4 and CD8 counts normal. Bone marrow FISH positive for translocation 14-18. This is the most common indolent lymphoma. Grade is based on the number of centroblasts per high power field. Grade 1 would be 0 to 5 centroblasts per high power field. Grade 2, 6 to 15 centroblasts per high power field. And grade 3 is more than 15 centroblasts, and you must treat these as diffuse large B-cell lymphoma. The tumor cells will be CD20 positive, 10 positive, BCL6 positive, BCL2 positive, and CD5 negative, and up to 90% have translocation 14-18. Remember the Flippy index. You get 1 point for each. Number of lymph node areas more than 4, 1 point. Elevated LDH, age more than 60, hemoglobin less than 12, and over stage 3 or 4. The 5-year survival based on the Flippy score is of a 0 to 1, 90%, 2, 80%, and more than 3, 50%. As you can see, anytime in either the Flippy index, the IPI score, the IPS for Hodgkin's, anytime you have more than 3, the survival drops to 50%. Treatment of follicular lymphoma, stage 1 or 2, involve field radiotherapy alone. There's no data to support adding chemotherapy, and then follow every 3 to 6 months for 5 years. Stage 3 or 4, RCBP, which includes rituximab, cyclophosphamide, vincristine, and prednisone, FCR, fludarabine, cyclophosphamide, rituximab times 6 cycles, bendamustine times 6 cycles, and may consolidate with radioimmunotherapy such as yttrium-90, ebritumumab, and maintenance rituximab for 2 years. Remember, follicular lymphoma, there's maintenance rituximab. Relapse disease, if alkylating agent worked for more than 2 years, then may use again. You may escalate to R-CHOP or radioimmunotherapy, yttrium-90, ebritumumab, or iodine-131 tocilizumab. Remember, need to have less than 25% bone marrow involvement by follicular lymphoma, since it may cause prolonged cytopenias. May consider bendamustine, autologous stem cell transplant in very selected cases, and allo transplant may potentially be curative in young selected patients. Important to remember, if new B symptoms, rising LDH, one nodal area is growing rapidly than others, or if there's increased SCV uptake on PET scan, consider a transformation to diffuse large B-cell lymphoma and obtain new biopsy. If positive, then consider chemotherapy. In a partial or complete response, then stem cell transplant is feasible. Marginal zone lymphoma. There's 3 subtypes of marginal zone lymphoma. 1. Nodal marginal zone lymphoma. 2. Extranodal marginal zone lymphoma or MALT lymphoma. And 3. Splenic marginal zone lymphoma. The immunophenotype is characterized by expression of CD43, CD20, the lack of CD5 or CD10. Remember CD43. Nodal marginal zone lymphoma case report. 59-year-old male with a history of hepatitis C, presenting with right inguinal lymphadenopathy. Immunohistochemistry revealing false positive for CD20, CD43, indicating B-cell phenotype, and negative for CD3, 5, 10, 23, BCL6. Kappa light chain restriction is discovered, confirming monoclonality of B-cell proliferation. CT scan reveals lymph nodes enlarged only in the inguinal region. Bone marrow biopsy negative for lymphoma involvement, and FISH positive for translocation 11-18. Remember that translocation. 25% of the time is associated with hepatitis C infection. Make sure the proper imaging workup is done, including CT chest abdomen and pelvis, EGD colonoscopy, to rule out possible coexisting extranodal MALT. Nodal marginal zone lymphoma treatment. If it's stage 1 or 2, involve field radiation therapy and then follow every 3 to 6 months. Stages 3 or 4 are symptomatic, which means threatening organ function, cytopenias, and bulky disease. Then consider RCVP times 6 or FCR times 6, bendamustine, or R-CHOP. MALT lymphomas, extranodal marginal zone lymphomas. Case report. 47-year-old man presents to the emergency department with fever, left-sided chest pain. Chest radiograph reveals massive consolidation of the basal segments of the left lower lobe. IV antibiotics are initiated. Chest radiograph the following day shows marked progression of the pleural effusion. Left thoracotomy and decortication are done. Pathology revealing, keyword, dense band-like infiltrates of small lymphocytes and plasma cells with cytologic atypia suggestive of low-grade lymphoma. The immunohistochemical study of the infiltrate reveals that small lymphocytes CD B-cell lineage CD20 positive, CD43 positive, CD5 negative, with plasma cell population demonstrating IgM monoclonality. There is no expression of the markers CD5, 10, 23, and BCL6 and cyclin D1. Remember, cyclin D1, think mantle cell lymphoma. Tumor tissue FISH positive for translocation 11-18. Extranodal marginal zone B-cell lymphoma, also called low-grade B-cell lymphoma of mucus-associated lymphoid tissue, MALT, is an extranodal lymphoma that arises in a number of epithelial tissues, including stomach, thyroid, salivary gland, lung, and small bowel. Extranodal marginal zone is postulated to arise from post-germinal center memory B cells. The extranodal marginal zone of the lung is sometimes referred to as bronchial-associated lymphoid tissue lymphoma. It's characterized by chromosome translocation 11-18, uses the apoptosis inhibitor 2 gene on chromosome 11 with MALT1 gene on chromosome 18. Other pathophysiologic mechanism in extranodal marginal zone is infection or autoimmunity, related chronic inflammation leading to local accumulation and proliferation of antigen-dependent B cells and T cells, such as H. pylori and gastric MALT. Other infectious organisms include Borrelia, cutaneous marginal zone, chlamydia, ocular adnexal marginal zone, and Campylobacter, small intestine marginal zone. If gastric MALT fails to respond to H. pylori treatment, repeat endoscopy in 3 to 6 months and treat with radiation therapy if disease persists. Important to know, if stage 1 MALT is resected, there is no need for chemotherapy or radiation therapy. Non-gastric MALT treatment, limited stage 1 or 2 local therapy, advanced stage 3 or 4 treatment is similar to other indolent lymphomas, such as RCVP or FCR. Splenic marginal zone lymphoma, case report. A 67-year-old male with a history of hepatitis C, important, presenting with complaints of left-sided abdominal fullness and noted to have splenomegaly on physical exam. Lab evaluation reveals pancytopenia and a serum and component is detected. The spleen is removed and weighs 1,500 grams, very large. Histology reveals prominent white pulp with an expanded marginal zone. The neoplastic cells are marginal zone type cells with small to intermediate-sized nuclei with occasional conspicuous nuclei and moderate amount of pale to amphiphilic cytoplasm. Important words. Immunophenotype analysis reveals a B-cell population which is CD20 positive and 43 positive with capital light chain restriction. Think of splenic marginal zone in older patient presenting with isolated splenomegaly and pancytopenia. Bone marrow involvement is very common without other lymphadenopathy. Associated with hepatitis C virus, sometimes may treat the lymphoma if you can clear the hepatitis C virus with antiviral therapy. Treatment if asymptomatic observed. If symptomatic, treat hepatitis C, rituximab, and splenectomy. Primary mediastinal large B-cell lymphoma. Case report. 36-year-old female presenting with shortness of breath and bulky anterior mediastinal mass. The cells lack surface immunoglobulin expression but express CD19, 20, weak 30, and 30% of cells. Remember, if it's more than 80%, think Hodgkin's with a mediastinal mass. Primary mediastinal large B-cell lymphoma of the mediastinum is a diffuse large B-cell lymphoma arising in the mediastinum from the thymic B-cells. Primary mediastinal large B-cell lymphoma is characterized by rapid growth, large bulk, and airily local and extranodal extension in the absence of generalized lymphadenopathy. Since fibrosis is often extensive, needle aspiration or even excisional biopsy will often not lead to the diagnosis. The surgical biopsy via the Chamberlain anterior mediastinoscopy procedure is performed. Superior vena cava syndrome is common as is involvement of the pericardium. Treatment, R-CHOP times 6, followed by radiation of the mediastinum, or DAR-EPOCH, or Armacop-B. Primary cutaneous B-cell lymphoma. 70-year-old man presenting with a rapidly growing ulcer-proliferative lesion on the right upper limb. Biopsy of the lesion reveals a primary cutaneous CD20 positive diffuse large B-cell lymphoma. There is no evidence of systemic involvement on CT. Local radiotherapy induces complete remission of the B-cells. Cutaneous lymphomas represent a unique group of lymphomas and are the second most frequent extranodal lymphomas. They can be defined as lymphoproliferative skin infiltrates of T cells, B cells, or NK cells lineage, which primarily occur in and remain confined to the skin, in most patients without detectable extracutaneous manifestations at diagnosis. B-cell lymphomas account for the majority of nodal lymphomas, whereas in the skin, primary cutaneous B-cell lymphomas represent only 20 to 25% of all cutaneous lymphomas. Primary cutaneous B-cell lymphoma categories are 1. Primary cutaneous follicle cell lymphoma, 2. Primary cutaneous marginal zone lymphoma, 3. Primary cutaneous large B-cell lymphoma, leg type, which is the most aggressive type. Because cutaneous B-cell lymphomas have an overall favorable prognosis, proper recognition is vital for appropriate therapy to avoid overtreatment in most cases. Organism initiating cutaneous B-cell lymphoma can be Borrelia burgdorferi. Treatment if localized, local radiation therapy or surgical resection. If aggressive, R-CHOP. If disseminated, topical steroids, rituximab, and chemotherapy. Hairy cell leukemia, case report. 55-year-old male presenting with weakness, splenomegaly, fever, and pancytopenia. Bone marrow aspirate attempt is unsuccessful, dry tap, very important. Bone marrow biopsy demonstrates a mononuclear cell infiltrate with keyword a fried egg appearance of a halo around the nuclei and increased reticulin as well as collagen fibrosis. The cells are positive for 19, 20, and two things you absolutely must need to know, 25 and 103. Rare but important disease and often asked on the boards because it has a very high response rate to purine analog treatment. If you see CD103 and 25 in splenomegaly, think hairy cell leukemia. Treatment, cladribine or pentostatin plus or minus rituximab. Indolent, peripheral T-cell lymphomas, mycosis fungoides and Sézary syndrome. Case report. 46-year-old male presenting with plaques and patches on the skin which have evolved to cutaneous nodules and diffuse erythroderma. Patient does not improve with anti-psoriasis treatment. Biopsy and immunophenotypic analysis reveals T-cell markers, typically with CD4 positive, CD8 negative, so T helper cells, as well as CD3 positive and CD5 positive with CD7 deletion. Important to know. Mycosis fungoides refers to disease when it is only confined to the skin. Sézary syndrome refers to disease progression to nodal disease and organ infiltration, and circulating clonal T cells representing the advanced stage of the disease. Treatment, mycosis fungoides, topical nitrogen mustard, steroids, retinoids, radiotherapy, cutaneous photochemotherapy with oral Sorolin plus ultraviolet light A, PUVA. Sézary syndrome, consider methotrexate, steroids, deniliquin detox, retinoids, interferon alpha, and HIDAC inhibitors such as vorinostat or romidepsin. Mantle cell lymphoma. Case report. 58-year-old male presenting with anemia, epigastric pain because there's gastric involvement, lymphadenopathy above and below the diaphragm. Bone marrow biopsy reveals infiltration with lymphoma cells expressing CD20, CD5, and negative for CD23. Very important. FISH positive for translocation 1114, which is a cyclin D1. Extranodal involvement, especially in the GI tract, is common, may occasionally presenting with multiple intestinal polyps and intestinal obstruction or intussusception. Upper endoscopy and colonoscopy should be done routinely as part of staging, therefore. Cells are CD20 positive, 5 positive, but 23 negative. Remember, CLL will be 5 positive and 23 positive. Associated with translocation 1114, cyclin D1, marginal zone ranges in disease severity from smoldering chronic to very aggressive. Uncommonly, patients with mantle cell lymphoma may have marked lymphocytosis mimicking pro-lymphocytic leukemia, the PLL, but they'll be translocation 1114 positive, and that's how you differentiate the two. Median survival only 3 to 4 years and a very difficult disease to treat with high rate of relapse. Treatment for a young patient less than 65 with a blastic aggressive variant of mantle cell or high IPI index would be chemotherapy and autologous stem cell transplant consolidation. Chemotherapy may be either R-CHOP or hyper-CVAD. Treatment for older patient, less aggressive disease or a low IPI would be chemotherapy, and if patient relapses and is chemotherapy sensitive, then proceed with auto-transplant. Treatment of relapse disease may include bortezomib, rituximab, carbendamustine, lenalidomide being considered, and allogeneic stem cell transplantation the only option for potential cure, but the role is uncertain at this point. Primary B-cell testicular lymphoma. Case report. 65-year-old man presenting with a 1-month history of testicular swelling. Patient submitted to right inguinal orchiectomy for definitive diagnosis. Light microscopy demonstrates a sheet of lymphoma cells involving the epididymis and retate testes, but mainly extended into testicular parenchyma. Malignant cells are large with scant cytoplasm and large vesicular nuclei, the classic appearance of a diffuse large B-cell lymphoma. The immunohistochemical study is carried out with the tumor cells being intensely positive for CD20, 45, and Ki67. Poor prognosis due to distal recurrences, especially the brain. Remember that primary B-cell testicular lymphoma is an extranodal disease, so irrespective of stage, treatment consists of R-CHOP times 6, plus radiation to the involved testicle, as well as prophylactic radiation to the contralateral testes, and intrathecal prophylaxis. Primary cutaneous anaplastic large T-cell lymphoma. Case report. 55-year-old man presenting with a nodule on his right lower thigh. No superficial lymph nodes are palpable. Bone marrow biopsy as well as CT chest, abdomen, and pelvis are negative. Skin biopsy confirms tumor reveals diffuse infiltration of anaplastic large cells to the dermis. Multinucleated cells and mitotic figures are frequently seen. The tumor cells are CD30 positive, keyword 4 positive, 25 positive, 45 positive, 3 negative, and 20 negative, and anaplastic lymphoma kinase negative. Southern blotting with DNA from the lesion reveals clonal rearrangement of T-cell receptor, proving a clonal T-cell population. CD30 positive primary cutaneous anaplastic large cell T-cell lymphomas have a better prognosis than their CD30 negative counterpart. One of the specific characteristics of the primary cutaneous anaplastic large cell T-cell lymphoma is that most cases reveal a non-aggressive clinical course with a favorable outcome in spite of tumor cells being histologically high grade, whereas the systemic anaplastic T-cell lymphoma have a poor prognosis. Treatment: locally advanced skin involvement, consider topical steroids, ultraviolet therapy, surgical resection, or radiation therapy. In advanced disease, CHOP. Peripheral T-cell lymphoma. Case report: 39-year-old woman presents with abdominal discomfort. CT scan of the abdomen and pelvis reveals a large abdominal pelvic mass surrounding the small bowel omentum. Lymphoma cells from the excisional biopsy of the mass are hypercellular and composed of a population of monotonous, non-cohesive cells with a high nuclear to cytoplasmic ratio and a single prominent central nucleolus. The cells are CD3 positive and CD43 positive, but negative for keratin, which rules out carcinoma, kappa lambda rules out B cells, S100 rules out melanoma, CE8 rules out colon cancer, negative for CD20 rules out B cell, negative 34 and 30 negative rules out myeloid marker, negative 56 rules out NK cells. T-cell lymphomas generally have a worse prognosis than B-cell lymphomas, but remember, an adult T-cell ALL has better prognosis than adult B-cell ALL. There's some evidence that primary cutaneous T-cell lymphomas have higher expression of P-glycoprotein, so they're more resistant to chemotherapy. This might explain the worse prognosis than B cells, also the fact that there's not a rituximab equivalent for T cells yet, except in ALK-positive anaplastic large cell lymphomas, which have a better prognosis. Treatment: early stage, stage 1 or 2, limited CHOP plus or minus radiation therapy, except if early stage consists of bulky disease more than 10 centimeters, in which case you must treat at stage 3 or 4. An extensive disease, stage 3 or 4, CHOP times 6, or hyper-CVAD plus or minus radiation therapy, and consider autologous transplant for consolidation for high IPI patients in first complete remission, since they are high risk for relapse. In relapse, any salvage chemotherapy regimen that chemotherapy sensitive, then consolidate with allogeneic stem cell transplant or a clinical trial. Remember, pralatrexate, 40% will respond in relapse setting after the second cycle, so be patient. Also remember to co-administer folate and B12 to alleviate severe mucositis. May also use gemcitabine, etoposide, romidepsin, denileukin, or alemtuzumab. Aggressive NK cell leukemia lymphoma. Case report: 43-year-old man from China, presenting with anemia, thrombocytopenia, shortness of breath, fever, elevated PTT, low fibrinogen, basically patient in DIC. Bone marrow biopsy for lymphoma involvement. Immunophenotype reveals CD3 negative, 4 negative, 5 negative, 8 negative, 20 negative, 45 positive, very important, 56 positive, that's NK cell marker, and CD68 negative. Epstein-Barr PCR positive. B and T cell gene rearrangements are negative. Think of natural killer leukemia lymphoma as two broad categories, the nasal type and the non-nasal type, associated with Epstein-Barr virus infection and seen mostly in Asia. Patients often have constitutional symptoms and multi-organ failure with coagulopathy, DIC. Treatment: CHOP, hyper-CVAD, poor prognosis. Large granular lymphocyte leukemia. Case report: 50-year-old man with rheumatoid arthritis, presenting with fever, neutropenia, and splenomegaly. WBC 53,000 with 90% atypical lymphocytes, 5% neutrophils, hemoglobin 14, platelet count 59,000, normal PT-PTT. So remember, neutropenia and splenomegaly, think LGL leukemia. Peripheral blood smear revealing atypical lymphocytes that constitute 90% of the white cell population. Bone marrow biopsy with aspirate revealing a hypercellular marrow with diffuse replacement by an atypical lymphoid infiltrate, accounting for 70% of the overall cellularity. Flow demonstrating a CDT positive, CD3 positive, 8 positive, 56 positive, 57 positive immunophenotype. T-cell receptor southern blot positive for rearrangement of the TCR, confirming a T-cell monoclonal population. Severe neutropenia, less than 500 ANC, with lymphocytosis is suggestive of Felipe syndrome in patients with rheumatoid arthritis. LGS or CD3 positive T cells are less commonly CD56 positive NK cells. Neutropenia related to fast-mediated neutrophil cell death, but in Felipe syndrome is caused by autoimmune destruction. Need T-cell receptor gene rearrangement to discriminate the CD3 positive cells from CD56 positive NK cells. Treatment, methotrexate, cyclosporin A, chlorambucil, cyclophosphamide, or steroids. Extranodal NK/T-cell lymphoma nasal type. Case report. 43-year-old Asian male presenting with nasal discharge. The exam of the right nares reveals a mass which is biopsy revealing keywords small, medium, and large atypical lymphoid cells infiltrating fat lobules with necrotic foci and, very important, granulomatous reaction. If you see that word, think extranodal NK T-cell lymphoma, as well as angiocentric and angiodestructive infiltrate of atypical mononuclear cells in a background of zonal necrosis. Immunostaining demonstrating the atypical lymphoid cells marked as CD3, cytoplasmic positive, CD56 positive, remember 56 is NK cells, but CD5 negative, that T-cell marker, 20 negative, 15 negative, 30 negative, EBER positive, Epstein-Barr positive. Nasal type NK T-cell lymphoma is most common in Asia and in the native populations of Central and South America. Pathogenesis is related to the infection of tumor cells with Epstein-Barr virus. NK cells will be CD56 positive. Treatment, radiation therapy plus or minus methotrexate. Angioimmunoblastic T-cell lymphoma. Case report. 7-year-old man presenting with fever, night sweats, rash, and arthralgias. Physical exam reveals macular rash, diffuse lymphadenopathy, and hepatosplenomegaly. Excisional biopsy illustrates vascular proliferation with keywords perivascular, atypical, medium-sized lymphoid cells with Reed servant-like cells, which are CD4 positive, 21 positive, 10 positive, BCL6 positive, CXCL13 positive. Follicular dendritic cell network and prominent arborizing high endothelial venules. Hypergammaglobulinemia detected with elevated LDH and ESR. Angioimmunoblastic T-cell lymphomas, formerly known as angioimmunoblastic lymphadenopathy, with dysproteinemia, believed to be derived from the CD4 positive T cells. Accounts for 15 to 20% of T-cell malignant diseases in adults, so fairly not uncommon. Angioimmunoblastic T-cell lymphoma is a clonal T-cell disorder involving deregulation of B cells and endothelial cells against a background involving a unique malignant microenvironment. The clinical course tends to be aggressive, and median survival is less than 3 years. Treatment, CHOP. Anaplastic large cell lymphoma. Case report. 37-year-old male presenting with low-grade fever, low back pain, and weight loss. He's thin with pallor and has generalized lymphadenopathy, as well as hepatosplenomegaly. Excisional biopsy of the lymph node reveals keyword infiltration by markedly atypical cells having hyperchromatic nuclei and prominent nucleoli. Immunohistochemistry for CD3 shows a strong Golgi zone positivity, very important, very nuclear. CD15 negative, CD20 negative, EBER, Epstein-Barr negative, and FISH positive for translocation 2,5, which is the anaplastic lymphoma kinase protein. Anaplastic large cell lymphoma is usually caused by CD30 T cells. 70% will have translocation 2,5. The product of this fusion gene may be identified by immunohistochemistry using antiserum to ALK protein, will have better prognosis of ALK positive. The study has found an increased risk of anaplastic large cell lymphoma of the breast in women with silicone breast implants. Treatment for ALK negative, CHOP and consider stem cell transplant consolidation. If ALK positive or low IPI or ALK negative, low IPI, then CHOP and await possible relapse. Relapse disease, brentuximab has just been approved. Primary CNS lymphoma. 45-year-old HIV-positive male presents with odd behavior and personality changes. MRI of the brain reveals enhancing mass in the frontal lobe. CSF flow cytometry positive for CD10 and BCL6 lymphoma cell. Epstein-Barr PCR positive in the CSF. You must have that. Slit lamp exam must be done. Reveals lymphomatous involvement of the vitreous space of the eye. Primary CNS lymphoma is a rare and may occur in immunocompetent patients or in association with immunosuppression related to HIV infection, as well as organ or marrow transplantation. Slit lamp exam is essential as could have up to 25% ocular involvement, in which will require intraocular radiation therapy and higher doses of IV methotrexate. Treatment: high-dose IV methotrexate as well as intrathecal chemotherapy with CSF positive for lymphoma. If slit lamp exam is positive, then biocular radiation therapy. Do not administer radiation therapy to the brain along with IV methotrexate unless patient has relapsed, since there's a high rate of dementia. If patient cannot tolerate high-dose IV methotrexate, then RT as first-line treatment. Adult T-cell leukemia and lymphoma. Case report. 46-year-old male from the Caribbean, or they could present someone from Japan, presents with fever, anemia, skin rash, hypercalcemia, and lytic bone lesions on skeletal surveys. So remember, if you see lytic lesions, think either Langerhans cell histiocytosis, adult T-cell leukemia and lymphoma, or myeloma. Bone marrow involvement with lymphoma cells positive for CD4 and, very important, CD25, but negative for CD7, negative for CD20. HTLV1 PCR positive. This occurs in the Caribbean and Southeast Asia, but mostly also in Japan. Adult T-cell leukemia and lymphoma is associated with HTLV infection. The virus encodes an oncoprotein called the TAX protein. Epidemiologic studies suggest that HTLV1 is primarily transmitted by breastfeeding, although spread via vertical transmission during childbirth, blood transfusions, sharing of needles, and sexual intercourse have been reported as well. Clinical course might be 4 different types. Acute, which includes systemic symptoms, lymphadenopathy, leukocytosis, hypercalcemia, elevated LDH, hepatosplenomegaly, lytic lesions, and skin lesions. 2. Lymphomatous, lymphadenopathy without blood involvement and elevated LDH. 3. Chronic, stable lymphocytosis and skin lesions without hepatosplenomegaly or hypercalcemia. 4. Smoldering, asymptomatic except skin and pulmonary lesions with normal lymphocyte count. Patients are effectively immunosuppressed. High risk for opportunistic infections as a result of this, such as PCP. Treatment: interferon and AZT improve overall survival benefit compared to chemotherapy. Patients have acute, chronic, or smoldering type, not the lymphomatous type. CHOP: poor prognosis in the aggressive type. Hyper-CVAD: for aggressive type, if complete response with initial induction therapy, consider continued treatment with AZT and interferon or allogeneic stem cell transplantation consolidation. Immunodeficiency-associated lymphoproliferative disorders. 3 main categories. 1. Primary immunodeficiency disorders, such as Wistock-Aldrich, ataxia-telangiectasia, common variable, or severe combined immunodeficiency. Typically, this is Epstein-Barr virus related. They poorly respond to standard treatment, so consider allo stem cell transplant. 2. HIV infection related, usually aggressive lymphomas, also Epstein-Barr virus driven. HIV-associated diffuse large B-cell lymphoma is treated with dose-adjusted EPOC, along with rituximab with CD4 count more than 50, rather than R-CHOP. Primary fusion lymphoma is herpes 8 driven, very poor prognosis. HART is essential as decreasing viral load and increasing CD4 counts will decrease risk of lymphoma and improve outcome after chemotherapy treatment. 3. Post-solid organ or marrow transplantation with iatrogenic immunosuppression, driven by immunosuppression, which may activate the Epstein-Barr virus. There's 2 types. If it occurs less than 1 year post-transplant, it's usually monoclonal and Epstein-Barr driven. If it occurs more than 1 year post-transplant, it's usually monoclonal and not Epstein-Barr driven, more aggressive. So for the less aggressive type, treat with decreasing immunosuppression and rituximab or infusion of EBV-specific cytotoxic lymphocytes. Treatment for the more aggressive type is R-CHOP x 6 of B cells and CHOP x 6 of T cells. Castleman's disease. 35-year-old male with a known history of HIV, presenting with cervical, axillary, and anal lymphadenopathy. Lymph node biopsy revealing keyword, shrunken germinal centers, with increased vascularity and expansion of the mantle zone with a quote-unquote onion skin pattern. Herpes 8 stain positive. Castleman's is characterized by adenopathy that is typically unicentric, although 10% of the patients may have multicentric disease. The plasmablastic variant is the most aggressive multifocal form. Etiology is due to elevated IL-6 levels, cytokine storm, which causes B and T lymphocyte polyclonal expansion. Herpes 8 producing IL-6 has been implicated. Treatment for unicentric disease is radiation therapy or local excision. For the aggressive multicentric disease, treat as aggressive lymphomas. This concludes the Non-Hodgkin Lymphoproliferative Disorders chapter. Thank you.